welcome you to the next session, which is called Living with Pain, Mental Health and Chronic Illness.
And today we are here to speak about very critical but often overlooked aspect of chronic disease, which is the emotional and psychological aspects of somebody who's dealing with chronic disease. So the definition of chronic disease is a disease which persists for more than 3 months and might progressively worsen. In most cases, there is no cure, only management. And patients have to deal with symptoms on a daily basis. So you can imagine in our busy lives, somebody has to deal with wheezing or irritable bowel syndrome every single day. What is going to be his quality of life? So that is the reason I felt that, this is something which needs to be addressed. And I have 2 very esteemed medical professionals with me. One is Dr. Vishal Rao, and to, enumerate both of them, achievements and qualifications would take us most of the hour, but I'll try in 2 minutes. Dr. Vishal Rao is an oncosurgeon. He is the Dean of Academic Research at the HCG Group of Hospitals. And he is also the Country Director, Head and Neck Surgical Oncology at HCG Cancer Care. Dr. Vishal has more than 100 publications to his name and has been conferred with many international and national awards. He's also on the panel of several government consultative groups. Dr. Vishal is also an inventor, and he has several patents in medical devices as well as drugs. And a notable one being OM, which is a prosthetic unit for patients who have undergone, voice box surgery. And my next guest is an equally esteemed doctor. He is a senior consultant at Apollo Group. He has established and he leads the Apollo Institute of Colorectal Surgery. He has also authored several papers, and he has lectured both nationally and internationally, and especially on precision oncology, psycho-oncology, decision-making, as well as health outcomes in surgery. He's also an innovator, and he is, has a project called CAFRE, which focuses on prevention, which he believes is key to success. And the topic for this discussion came from my own personal lived experience. I lost my mother last year to stage 4 ovarian cancer. It is an aggressive cancer, and there was very little time between diagnosis and death. And both me and my sister are medical doctors, and despite being medically informed and despite her being in the care of the best in the group, in the world, in India, in terms of cancer care, the medical protocols were followed, but the emotional and psychological aspects, she was left, largely on her own. So her compass and savior at that point of time was her family, but we're not all lucky to have that. And it need not be so. So these are the glaring health gaps that we saw when somebody who is well knowledgeable and well connected to the medical community can experience. So you can also just imagine what an average person diagnosed with a terminal disease or a chronic debilitating disease can go through. And as of now, I don't really see a lot of redressal in that space. So because chronic illness, it's not just pain, it also affects the way the person sees himself, his relationship with his family, his relationship with society, and also how he views his future. So with that, I think let's start this discussion. I would like to ask, I'll start with Dr. Narasimhan. Doctor, what are the most common psychological challenges you observe in patients with chronic disease, when you treat them?
Thank you, Priya. First of all, it's an absolute delight to be here. And I think an hour is probably too less to dwell upon such a very vital, important topic of chronic illness and pain. I think on a broader perspective, before I attend to Priya's question, let us start looking into what actually is health. Have we really thought about what health really means? what wellness is, what illness is. How do we define it? I think it's very important to define this. And if you look at the current World Health Organization definition, which comes in from actually Sigmund Freud's work, it's a balance that is struck between the physical, physiological or the functional, and psychosocial well-being. And this is what wellness or health is defined as. And if you look at it, at any one point of time, all of us have been through illness. We have been through suffering. Let us take back 3-4 years ago when COVID struck us. We were all psychosocially debilitated, hit. We were isolated. We were not mixing with people. We were socially not well. Which essentially meant we all went through a phase of being ill, the whole world as such. And this is in terms of the general population we talk about. What we doctors are normally good at is, we are good at making people live. But what we are bad at is, we're not good at making people live well. I think this is the difference we all have to draw when we actually look at health, wellness, and how we can actually define wellness. It's a larger topic per se, but when Madam talked about how do you cope with pain, psychological illnesses, it's a much broader topic. I mean, to put it precisely, we have patients who go through trouble and pain. And we in the medical terminology call them as when there is a hit, either medically or effects that come as a consequence of a medical therapy, we call them as first victims. For example, I create a complication, I do an operation, there has been a consequence of the operation, they all fall into being first victims. Who's the second victim here? Second victim is the clinician who has imposed this inflict on the patient. And what the clinician goes through, what the paramedical staff goes through is certainly not something we talk about. And the amount of pain and the suffering and the grief that a clinician goes through or a caretaker goes through is second to none. The third victim we talk about is the immediate next of the family. So I think it's such a broad topic. When Priya asked me, what is the psychological impact? Are we talking about the psychological impact on the first victim? Are we really talking about the psychological impact on the clinician or the caregiver, which is the second and the third victim respectively? And I think we suffer, whether it is a third victim, which is the family, or it's the second victim as clinicians, we suffer. Patients can speak. I mean, it's very difficult for us to speak out. I go through pain, suffering, and next day I have to be back to my normality doing what I do. So I think the psychological impact that one has is, we go through depression, we go through anxiety spells, we go through dysthymia, we go through ups and downs. And it is something that we have not touched upon. And it's certainly something that needs a lot of attention, not only to the patient, but also to the second and the third victim respectively. Thank you.
Dr. Vishal, you want to add to it? Or?
No, I think he's covered it quite well, but I think I'll go make a little bold statement here to say that with modern medicine, we've actually practically eliminated pain. And I want to say that now that's something that we need to really think about. So I'll just give you a very, just about a week back, I had a patient who came to me who was wheeled in with a trolley. Extremely, they were being moved to a palliative care center. And before that, they came to take my opinion in an ambulance. And they couldn't even move the patient into my outpatient. And while I came out, I saw the lady, she had a tumor which was bleeding, withering in pain, unbearable. So I sat next to her, held her hand, spoke to her for 2 minutes, and I asked her, I said, how many days have you not slept? And she said, 1 week. And I said, how bad is the pain? She said, the pain doesn't let me sleep. I'm just initiated something. And I said, forget about which stage of the cancer, what tumor, what all of this. I said, let's not look at PET scan, what drug. We are talking about 2 things which I can immediately address. And I was thinking, why is it that we've not even addressed it at this point in time, through all of this? This is the first time I met her. So what kept disturbing me was, why can't we, this is modern medicine. I mean, come on, we can't just say that you can't give her sleep and you can't relieve her pain. So I just took one more step further. I had my senior fellow, one of the fellows, doctors, a specialist with me. I talked to him and I said, today, evening, if she doesn't sleep, you don't sleep, and I don't sleep. Simple. I said, let's start with that. Modern medicine, we can eliminate pain. I'm taking it up as a challenge. I said, come on, let's do it. Now I'm saying that night we didn't get that call. She slept. And I'm saying just one small difference of intervening correctly with the right intent. We don't need to, I was telling my doctors, look, you don't need to have these double degree, triple degree to become human, to become and solve the most basic fragment denominator of pain. And that one single thing, and I've seen her about a day earlier, the difference was she came walking. Now that small switch, forget about, I think oncologically she'll do well if I'm able to switch this. So Preeti, that's the point I wanted to make here to say, I think we are at a point in science and technology when if we have the right intent and the right ecosystem, we can address these simple things and at the most grassroots level. So this is not something only for the elite I'm talking about. This is something for the most basic at a PHC level, at the level of a Gram Panchayat, I should be able to solve this. So it's a great topic today for us. And I think already doctor has touched upon the second victim and the aspect of pain there. I think there's a lot in this area which we can all open up to, but primarily I've been more interested in talking about dying than living with pain. I know we are all talking about living with pain, but I'm saying, the whole discussion in life is about celebrating life, importance to life. The part of dying becomes a little diluted here. I think we should focus a little more on dying because these people, there's something very beautiful going on there. Even in the process of the pain that they're going through, which we can solve, and that, if you're able to intervene, I think is tremendously, thousandfold more meaningful than the living part of it.
Thanks, Dr. Vishal. So I know that you wear many hats. So how has your approach to patient care evolved to address both the physical and emotional aspects of chronic disease, especially in your case when there's a patient of head and neck cancer and he might require face deforming surgery and then that affects every aspect of his life. How was it in the beginning and how has it changed and how is it now and how can it change more?
Couple of quick things of my learning. Most of my best learnings came from patients who taught me. Most inspiring ones came from patients. Today, my outlook has been importance of prehabilitation equally important as rehabilitation. So you need to really look at what's the baseline. So we started with one very simple thing of using the WHO distress thermometer. Just Google it up, it's available free on the net. You can actually go through it and have every patient give you a list of what's their social, psychological, physical status. Now that's a decent baseline to start with, I would say. Standardized, well acknowledged across the world. So I started with that initiative of using the distress thermometer. Looking at prehabilitation. What is the ambient level of stress the person is facing? And based on that, because in your short consultation, they say in an average in India, your consultation on an average is about 2 minutes it seems. In oncology, you need to spend literally another about 30 to 45 minutes with each patient to address each one of these issues. Typical Indian scenario, shortage of staff, overburdened doctor, all of this. So the question is, how do we ensure we give them that time? I think it's a very valuable therapy. Time of a doctor is the most valuable therapy I could offer. And I learned that from patients to say, forget about your technology, your robots and the other things. Just when you sit down and spend time with them and say, I'm not in a hurry. Until your last question is over, I'm here to listen to you and speak. Makes a huge difference. Second thing I felt was two important lessons which two patients taught me, and I'll quickly summarize that. One, when I was in Pittsburgh, I remember Dr. Stanley Wechsler, who was the then director of Brentwood Medical Center, gave me a very interesting thing. He showed me his file when I stayed with him. Flipped through it, I told him, I said, so stage 4C, metastatic, he had colon cancer with liver, lung mets, completed palliative chemotherapy. He was asked to go home. So I was talking to him and telling him, I said, what do you think could we both be talking on? And at that time I was working on angiogenesis. After going through all of the reports, the one single comment he told me, Vishal, you don't know how to read my reports. So I said, this is very paradoxical. What more is there to add in this? He said, you didn't check the date. So when I opened that date, it was 10 years back. So a man had lived through that entire thing, and I'm talking about a director of a medical center, a doctor, who's not tried some random thing and who's just telling something of his own. A structured approach to science, what he spoke about. And my period in Pittsburgh, I only remember him because all through his narratives of what he did and how he integrated all approaches of medicine excited me. The second I'm saying, as another person who's a cricket journalist, I was called at 11 p.m. at night to come and see him because I had actually, I'd been with him from his time of his marriage, fixing that to meeting both the parents and till the point when he had metastatic cancers. And at that point, I remember they told me that he's in the ICU, he's bled a lot in the lungs. And before dying, he would want to meet you. And the coffin had come to shift him. I remember that night, I had a discussion with that physician, discussing, let's make that last attempt to try and see if we can stop that bleed. And they said, everything we've tried has failed. Anyway, he was slightly out of sedation. I held his hand. We did a thumbs up to each other. And I said, you played your part. I came out and I told my colleagues, I said, let's give one more shot. Let's give it one more shot. Night, they did that, and by morning the bleeding had stopped. Okay, and he was on the ventilator still. Now my interesting thing for me of the learning was, they asked me, what do you do next? I said, keep it going. So day 2, he was okay. And day 3, he was out of the ventilator. I mean, it's a long story, but they asked me on day 3 what to do. I said, send the coffin back. I said, maybe we've got work to do with him. It's the first time in my life I sent a coffin back. And that's the time I realized from that patient, never give a time frame to somebody. Never give. This patient had 1 hour left. The coffin was ready. Everything was done. So I said, what are we giving time frames here for? For whom? I mean, we are not astrologers. And these are these patients who taught me that valuable lesson, never give a time frame to somebody. And Preeti, I just want to summarize with these 2 points, saying, I think one thing is, look at never giving a time frame to people. Stan and this gentleman, he wrote a very beautiful book. Please Google it up. It's called The History of Women Cricket in India. The Fire Burns Blue. That was the book he wrote in the ICU after he came out in the hospital. Published it, and such an inspiration. Now for me, this is a real life story, correct? A patient taught me something, saying that I had given a time frame, somebody else had given a time frame, he outbeat it. So the story of such people inspire us to say that books are written on them. So sometimes we as doctors put the book into the patient and kind of ensure that 8-month survival itna hai. There are statistical outliers. So my learning in this entire journey is, I think a lot of the time the truth is elusive. We really don't know what's in store. We need to reassure them, give them some time, and give your best shot to them on all aspects.
Thanks, Dr. Vishal. My next question would be to Dr. Narasimhan. Today, gut issues are everywhere, right from IBS, which used to be, and then all the sensitivity to lots of food. So how do you, and I believe this just can't be, addressed only with medicines. There are lifestyle strategies that you have to do. So how do you go about structuring those lifestyle changes, and which would be very major in some patients, and how much is their acceptability level and compliance to those lifestyle changes? Do they keep it up for life, or do they get better with it? So share some insights on that one.
I think pain is actually a Pandora's box. Let me take you back to Mother Nature, okay? There are animals fighting, there are injuries happening. Who takes care of them in the Mother Nature? The Lord is the doctor. There's no veterinarian going down trying to treat their pain. I think on the scale of 2 wide ends, we have somebody who takes care of the pain very well, the Mother Nature takes care, and on the other spectrum, we have an external intervention, such as a clinician, such as a pain specialist providing this intervention or pain relief. Where do we draw the line is the question. If a patient scientifically goes through some amount of pain, the body generates pheromones. The body generates the natural painkillers which actually help the patient. Coming to what Preeti just flagged us about, what about pain when it comes to gut issues. See, I take care of guts and both the butts. So I call myself a gut and a butt doctor. Unfortunately, what we are going through today is a state of civilizational poverty. Truly a state of civilizational poverty. Half the problems that we see today have cropped up because of our civilization. If I take back what you are today and put you in a remote corner of a rural setup with no technology, with no civilization, with no stress, that half the problems get better. A fifth of the patients I see are because of what they call themselves as IBS and come to me. Another fifth of the patients I see are proctological problems. I do a lot of cancer work, but I also do a lot of functional work, chronic pelvic pain. A very common terminology we see. And we see patients young and old alike. Very difficult to manage them. But the bottom line is, you need to figure out what the cause is. In fact, Preeti mentioned about fecal transplants or bugs or in the gut that can cause pain, so on and so forth. But if actually break it down, half the problems are self-made because of civilizational poverty. And the gut, 1 in 3 people suffer from gut problems. And everybody's threshold is different. There's a clear connect between the gyri, the brain, the bowel, the gut, and the gate, which is the bottom. And this connect is what is not being attended to. And we don't have gut psychiatrists here in India. But if you go to a place like UK or US, there are dedicated gut psychiatrists who sit down and attend to the patient, and half the time they are not on major painkillers, but they are on attending to the cause and trying to relieve the cause of. So I think there's a clear disconnect between the gyri, which is the brain, the bowel, and the back passage, which we don't attend to. Whether it is about the fast food we eat, whether it's of the lack of fiber we are attending to, it could be as simple as utilizing a Western toilet which has become a habit to us. And in fact, when the West is going towards East, we are going towards the West. Think about a small intervention, something called as a squatty potty, which is essentially a stool to squat. It is a $1 billion business in the US now, because when you squat, your evacuation is much better. And I don't know how many doctors are here or nurses are here or clinicians are here. People have colitis, non-specific colitis, distension in the bowel, bloating, pain, spasms. Doc, I've got IBS. Doc, I've got colitis. But do we actually know what it is? It is actually an inflammation the gut is going through. And pain is also a sort of inflammation that we all experience. Some have an intense pain, some have no pain. And this gut inflammation we see manifests as pain. People out there, you know what inflammation is? Inflammation is the effect, a consequence the body gives back to an insult. The insult could be a mechanical one. Think about a big slap you have. You have swelling, you have pain, you have redness, and you lose the function. Same is happening with the gut. And the cause is your processed food. The cause is your excess antibiotics. The cause is lack of balance or a lack of eubiosis in the gut, which all triggers to inflammation. Adding on is the state of mind. It is scientifically well proven that if you have a happy mind, a good hypothalamus that is driving wellness, your system is good. So I think the root cause is actually in the mother nature. The root cause is the mother nature not being treated well. The root cause is in how we nurture ourselves. Obesity, the biggest problem we are seeing. And more importantly, talking about the mental health, I don't think we are utilizing the mind to a great extent to alleviate our problems. So if we can correct the mother nature, nurture ourselves, and take care of the mind and utilize the strengths of the mind, I think it's half job done. So I think the gut and the butt issues, half of them I see, I deal with them through a psychologist, attend to the root cause problem, and let us create that balance which we had. I'll tell you, the number of bacteria we own, or rather, that's a wrong thing to say. I'm a part of a 40 trillion bacteria. I'm only a part of the biome. Unfortunately, we Homo sapiens think we are the superior ones, but the fact is we are only a part of them, and that is shown today that chronic pain could be related to the biome. Cancers are related to the biome. Anxiety is related to the biome. So there's a lot we are missing out on, and the more deeper we dig in, the less we understand. So I think when it comes to gut and butt pains, there's a lot to be said, and there's a lot to be corrected. More often than not, it's in the basics. Thank you.
Thanks, Dr. Narasimhan. And I will also like to ask Dr. Vishal, because you also do a lot of work in gut microbiome. Have you had success with patients, in your patients, where you have maybe made attempts to change the gut flora, and maybe that has relieved their mental, status and also physical symptoms to some? Is it part of a holistic approach to cancer besides chemotherapy and surgery?
So I think Dr. Narasimhan has very beautifully explained a lot of these points. I'll again go back to the basics of what I started with on my patients. The first one I said was, I asked them, the patient who came on the wheelchair, I asked, are you in pain? And have you slept? The third question I asked was, have you eaten? And when did you last eat? And that is again more than a week back she had eaten. Now I'm again going back to the three most important basic things in modern medicine which we can actually achieve in a very simple manner at the most grassroots level without spending too much. I said we can eliminate pain, we can give sleep, and we can feed. Today, between two of us, I think we should be able to just simply assure that the person can get feeding. So what I did to that patient was just feed that patient. Now today, I remember my days during the Tata in Mumbai. One of those regular evenings we used to go out because there used to be patients sleeping on the streets. And we used to go on feeding them because a lot of them were on Riles tube feeding. You see, it was such a busy OPD that we used to forget telling them that they have to eat well. I give a very common example and say, if somebody comes to me some days back and he was telling me, I've got stage 4C cancer, metastatic, all tumors. They were very depressed, upset, telling me, what do I do at this point, what more can be done? I was telling them, look at this PET scan, 10% of it could be cancer. The 90% is good cells. So while we are all discussing these 10, you've forgotten 90, correct? What is this 90 about? And as Dr. Narasimhan said, this 90 is about the immune system. And how does this immune system work? Air, water, food. So if you are not able to touch food, you're not going to be able to touch the immune system. You're not going to be able to touch anything else. So I would doubly emphasize and say in oncology, onco-nutrition has been terribly ignored in the world. In the world, I'm not talking about this. I was talking some time back to the Dean Ornish program in Harvard, and we are running something similar here on oncology, on onco-nutrition, and looking at just food as medicine, just reversing food as medicine. The power of food as medicine has been terribly underestimated, and I'm talking about allopathy, Ayurveda, all integrated together. There's so much we can do on reversing and working on cancer with just food. 1929, Otto Warburg got his Nobel Prize to say sugar is the only food for cancer. Today, I'm saying we are doing some interesting work with Cambridge and many other global universities to see how can we use food as medicine, integratedly. Simple formulas that can reverse cancer. And as doctor said, there is a proven work today that there is a gut-brain axis. It's very clear that there is a gut-brain axis, and this gut-brain axis decides everything. Whether you're happy, you're sad, you're stressed, everything is being decided by the gut-brain axis. To the extent now we are saying Alzheimer's, the cause lies in the gut. So I think serotonin, dopamine, all being secreted at the gut level. There's a lot of information out there. And what we are currently working on as a part of the research is to look at how are we going to use this information. And just to kind of give you all a dipstick, see, we have, how many genes do we have in our body? Take a guess. Like how many genes do we have? 20? 23,000 active genes. So totally about 30,000, correct? Baki thoda unko maaf kiya tha, because we still don't know what they're doing. So 30,000 total genes we have in our body. And we have 2 crore microbial genes. Now I remember the Time magazine, which actually came out with the first when Craig Venter's group created the first human genome project, they said the front page of the Time magazine in US was, "Your destiny lies in your DNA." Very interesting article. Craig Venter's group said, "Give us this million funding. We will tell you all the 30,000 genes ka kundli. We'll tell you who you are." 10 years later, a decade later, what happened was they came out with data. They said, "We have more questions than answers." Because they said, "This is like a piano. This is like a piano. We know now all of the, we know all of the
Notes.
Yeah, we know all of the notes. We know all the tones. What's surprising for us is who's playing these tones. So they said, we need more funding. You know, we are all researchers. We always need more funding, correct? So every time you go, you've solved one question, you've got to come up with another one. So they went back and said, we need more funding. And they said, what for? They said, we need the human epigenome project. Basically, we need to know who's the one stimulating this entire 30,000 genes. So the study went on, and that was more chaotic. Epigenome was actually everything. Like as I'm talking to you, your genome is changing. That is what epigenome said. That mind is a genome. Mind is an epigenome. Now, in all of these epigenomes, every factor, that means we talking, this panel discussion, everything, the food you ate, everything, they found one significant factor that was a contagious genome. So they said you could transfer your genes through a contagious way, and that was the gut microbiome. So that was one of the first big steps in epigenetic study, where they found that the gut microbiome could actually be controlling the entire universe of your body. And your psychology, your thinking, whether you're happy or sad, what's happening at this is all being, and that's when the science of gut microbiome actually picked up to understand and correlate. It's not enough to just study the tumor or cancer, but you need to also study the correlate of the gut and then understand what food is there that actually is processing this. So today, at the current point of research, I'll close with this to say that gut microbiomics we are at the next level of editing the gut. And we are at the point of inflection where we can say that we know the bugs who are there, and the current pre-probiotics are not able to crack it, because there is something out there which we are missing clearly. And with the Indian Institute of Science, we're doing some phenomenal work to try and figure out with longevity. And Preeti, that's something that's going to be the next generation. I mean, everybody here, I don't know how many of you all want to live to 100 years. All this discussion on this blue zones, centenarians, all of this happening. So it's the gut that is actually determining all of this here. It's the gut microbiome. So as the gut gets older, it gets leakier, and a lot of these the microbes that are seen in the youth are not found there. So a lot of the reverse aging discussion is now focused on the gut at this point in time. So I think the coming years you'll see a lot of interesting stuff happening only on gut editing, on the genome and the microbiomic editing at the gut level, customization of gut microbiomes. And I think that would lead to a complete new era of science for longevity, for centenarians, super centenarians, and all of this discussion. Just for your information and data, I was hearing from them saying that India has, they said US has 90,000 centenarians, Japan has 70,000. So being a part of the government, I took government's data on Karnataka's data. We found we had 22,146 odd centenarians, Karnataka alone. So I'm saying, where are we in India? I mean, why are we not talking about centenarians? And what are they doing? The answer lies in the mother nature in the village, where there's that lion and tiger sitting. We are, I think, in the wrong part of the world. Yeah.
Thanks, Dr. Vishal. So, Dr. Narasimham, I'll just like to touch a bit about the caregiver part of it. They also go through an entire labyrinth of emotions, and though they might not be the primary, people suffering from pain, it's another kind of pain that they suffer from. In your practice, is there some kind of module to address that? I know you're all very busy, and with my experience, I realized that the oncologist just gave me 10 minutes every time I took mom to him. So how do you aspect that part of the caregiver's journey?
I mean, Vishal is a surgeon, so I can speak. In India, it's a very cultural thing. So I did some research going back to 2012. I brought a whole team from the United Kingdom, and we were sitting in a tumor board discussion room at Narayana. And I was just asking them, how do you make decisions, folks? Tell us. Is it evidence? Is it patient making decision? Is it you making decision? Is it jointly you're making decision? And we had a bright young medical oncologist who stood up and said, "Doc, you're in the wrong place. In India, first it's God, next it's the medical oncologist." And he's a senior oncologist today. Okay, so what I'm trying to say is, I think we are actually looking at the wrong parameters. Let me bring the concept of quality of life and health-related quality of life to you. Let me push in some science here. How many of us actually think about quality of life? Am I eating well? Am I sleeping well? Is my sexual activity adequate? Am I socially active? Am I meeting people? Am I happy? I've had a hip replacement. I've had a cancer resection. Vishal does a lot of head and neck work and people with neck dissections and laryngectomies and whatever. Am I happy? I think that basic question we have not started asking in India so far. I think we should start looking at what is really troubling us. Is it the physical pain, or is the physiological functional pain, or is it the psychosocial pain? I think once we start asking, we'll start to know that we need to address it. And let me put it this way. We are in the land of Gautami, Buddha, where I think we know what spirituality is. We know death is a definite event. Likewise, I think the non-communicable diseases today is a definite event to a lot of us. Every family has got hypertension, diabetes, stroke, heart attacks, cancer. But we don't see diabetes as much as we see cancer as a monster. In fact, if you look at it, an earlier cancer caught and cured is much, much, much better than having diabetes for life. Why I'm coming to Preeti's question and trying to dwell deep into this is, I think there's more fear in us. Like we say, fear is more worse than the foe. We see cancer as a disease, but is it truly a disease? Is it really a disease? Something for you to question yourselves. The length of survival or the average lifespan, if I take you back to 1940, was about 38 years old. The average lifespan of an individual pre-independence in the late 30s was about 35, 38. People died of famine, people died of infections, people died of war crimes, whatever. But what are we living today? We're living up to 70 years today. That's the average lifespan. Mother Nature created women as a stronger being and they live more than us. 71 women and 69 men. That is in Karnataka. If you take back to Kashmir, they live up to 83. And more often than not, cancers are a stage of evolution. If you think about it, if you get a cancer, more often than not, you've actually lived long enough according to the average lifespan. But why are people getting cancers early? Because of the risk factors. So once we drive this concept to patients to say, boss, what you're going through is a stage of evolution. And I think, like Vishal rightly said, you need to actually start to enjoy what you have lived. And once they understand there's a problem, but there's a solution, they start coping better. So I think these basic concepts and principles that have been wrongly inserted into us, compelled on us, both by the industry, the community. We doctors are also at fault, so to say. How many of you would tell you that it's not a disease? I think this is what we need to start thinking about. And caregivers really go through a bad phase because they don't have anybody to seek help to. They need to support the patient. They need to stand up on their own. And they all go through depression, anxiety, pain, suffering. So I think as much as we look after the patient, there has to be some respite to the caregivers. And I think it is time that we look into caregivers to support them physically, physiologically, emotionally, and socially. And I think that is where groups like yours can really play a role, I think. Thank you.
Thanks, Dr. Simha. So, Dr. Vishal, I just wanted to ask you, have you encountered a very special kind of family or caregiver family in your experience from whom you have learned, how they have, the dignity in suffering, how they have managed it, navigated their way through it, and what could you take away from it and institutionalize it probably? Has something like that happened?
Yeah, I think I can quote one instance of a lady, again, late evening rounds, and it was just a random event that happened in the hospital that I'm in one of the towers next to the ICU, and this lady, the daughter of the patient, walks to me and says, "We've been your patients for 6 months back. You had operated on us, and after that, 2 months later, she had got cured, got better, and 6 months later, she developed metastasis. And we are with the medical oncologist now and treating, but the chemo has taken a toll. The tumor has spread, and she's terminal right now. She's in the ICU. She had a tube in the throat through which she was breathing. She had a peg tube through which she was being fed. She had a catheter. And I walked in to meet her. And when I walked in to meet her, I spent some time with her, and she wrote a note to me saying, "How much time do I have?" Actually, looking at the entire data and looking at all of it, it looked like a few hours left. So, as Nasim said, most importantly for caregivers today, I went back to her and I said, "Have you had a chat with your mother?" She said, "Sir, no, sir, we've told her that she'll be all right and to be strong." I said, No, you can't be telling that to her. I said, "You have to tell her the truth." I said, "You have to tell her the truth." And this is where I think we both agree upon the point, saying that it is the time for informed decisions. We are not here to take a decision, but we are here to help you take a decision, handle you till the point of that decision. And that's extremely crucial, the job of a doctor. If he's not able to do it, I think it's a real negative mark on our profession, that you have to handle the patient to a stage of informed decision. Today is the era of information overload. People get confused. They want to take second, third, fourth opinion, handle them, help them understand, give them the terminology on what you should Google, rather than let them randomly Google things and come to you. So, I feel bad when I get a consultation and I don't charge them because they know everything, So I'm just silently sitting, listening to all of them, and she's decided the procedure, the plan, everything, and the date of surgery. And then my anesthetist says, "Sir, aap thoda late aa jaiye," because they may teach you where to do that. So, I've been very, so I generally believe in the stage of informed decisions. It's very crucial. So this girl, I told her, "Look, let's handle you and let's take an informed decision. We have to tell her the truth." So I went inside, went back and wrote her a note. "You have a few hours left." That night she died. She wrote a long note for me and left behind, which I store. Very beautifully she wrote to me and told, "Thank you for telling me the truth. Thank you for explaining to me that I have minimal time left. You have been with me through this entire journey, and you've come today as a messenger of God to tell me, because in these few hours I prayed for my family, I prayed for my daughter, I prayed for my near and dear ones. I had to go. I had so much peace in me that I'm relieved." No, it was so beautiful. It was such a powerful letter for me that this lady taught me about simplicity of communicating the truth in a genuine manner. That night she passed away in peace, and I thought that a great lesson was taught for me on communication to her and her family, to tell that, "Look, come, let's handle and celebrate that." Life is not about celebrating life all the time. This society is so obsessed with life. I mean, the problem, and I prefer to attend more funerals than weddings, So I feel it's more meaningful because you actually get to see more reality there than you get to see on the other side. The most important thing of this is that you get to see the life of that patient, and that one page she wrote. I went back that day. I created in my hospital in the last few years what's a bereavement team, because I realized the simple thing that I missed there was, through the entire thing, one single patient, Preeti, led me to a policy. I went back and I checked with my team and I said, "Let's create a bereavement team so that when the patient, we know there is a time frame, can we fast track the billing? Can we fast track the desires of the family? Can the psychologists be involved to understand what was the desires, what are the things that they want to speak to her or she wants to speak to them? Can we have more conversations, meaningful, focused ones? Like an emergency surgery we do, can we have a proper emergency for what today we call in psychology the seventh sense? Or I think the entire process of handholding them through the psychological part of processing, while the billing team, the logistics team, the team from the discharge summary, the medical doctors counseling them on this, to understanding where the last rites want to be, what is the format of it, to what kind of prayers, or allowing them inside and saying, can you all sit with them and pray? Simple things that we started doing, which made a difference. And we brought down some of the time of bereavement, which would take 2 hours because of insurance issues and other things and all that, from 2 hours, 3 hours sometimes, to 15 minutes, 10 minutes, 7 minutes. And I said, that's meaningful impact. And I think that every hospital should have a bereavement team if you're dealing with something like this, because in my hospital, I see a death every day at least. And sometimes they're children, 6-month, 2-month-old children. So I think the point of a caregiver, especially in pediatric oncology and all, is paramount, very, very essential, urgent. Because I had a patient who was treating a 6-month-old child with chemo when she got cancer. Life can be very, very unfair. It's not. So I think the whole point is caregiver needs equally that amount of counseling as much as the patient to handhold them into this entire thing, and legally that is irrelevant for the doctor today.
Thanks, Dr. Vishal. So, Dr. Narasimhan, the next question is, as a doctor and a surgeon, there will always be setbacks. There can be medical complications, that can be antimicrobial resistance. It can be an operation failure too. And that can again give them set them back by depression and such. What is your strategy when you deal with, and again from a mental health point of view, because it's very easy to give up hope then, right? You've been through 6 or 7 surgeries and then you feel, okay, it's not worked, or you might get to reverse it. How do you keep patients motivated so that they still are up to it,
See, I'll take you back to an Irish man who actually taught me a lot of things, both on the professional front and a personal front. This man, who currently resides in the United States, called as John Monson, taught me 3 things. I mean, research days, you all know how research is, hard work, a lot of fees to pay to the university, you send your kids back home. Start the journey at 6 o'clock in the morning, reach at 6:30. Start your work, review papers, write articles, abstracts, vagara, vagara. So one day he called me, 6:30, he made a cup of tea and called me. And like a typical Indian, I went, folded my hands, put my hand down. Yes, prof. He said, drop your hands, lift your head. Okay. Next thing he said is, you Indian lads are very hardworking. But let me tell you 3 things that you learn for life. He made me to sit down, and then he said, always learn to be truthful. And if you don't know something, put your hand up and say, I don't know. Not now, even when you grow up, even when you're a doctor, a surgeon, or whatever, just say, if you don't know, say you don't know. The second thing you learn to do is, if you make a mistake, put your hand up and say, I'm sorry, it was my mistake. The third thing you do is ask for help, and if you can't do it, get him or her to somebody else. I think this is what I've followed even till today. And if you're open and truthful to yourself, especially in a corporate world of healthcare, half the problems are sorted. If there is a complication, you disclose that to the patient, because there's no fear out there. We call it as duty of candor, which means we have to disclose it and tell what happened if there has been a complication. Because without complications, operations can't happen. So as a part of my practice, I put my data and I call it my mool, my mistakes you learn, because mistakes are a part of the problem. So when you are open and transparent about things to the patients, there is no fear to worry about. You say, hey, there's been a mistake, but we have rectified it. We are sorry. And patients never feel bad about it. And in fact, they're grateful that you told them. And I have not had much of a problem following these 3 things. I mean, complications are a part of the problem. When it happens, you go through pain, they are going through pain. Seek help, seek colleagues to come down, ask them what your thought is, and solve the problem. I mean, patients out there are not there to blame you, not there to complain about you. And in fact, when you're open and transparent, they appreciate you much more. And the best friends I've had for life are patients who have had complications, their families. I think it's a bonding you build. Unfortunately, we have become too capitalistic in healthcare, and we become more a consumer and a service provider rather than a caregiver and a receiver. So I think to too much of money, we have lost that empathy, care, compassion. And let us be doctors. I think the words that go, Vaidyo Narayano Hari, are no more true to the Indian context now. In fact, they're more applicable to the Western context, I think. So I think when people go through, accept there has been a mistake, alleviate their pain. If there is a problem, seek help, be transparent, be upfront, and tell them, and things are normally okay. I think communication is the key here, and people will cope because, problems can happen to anybody.
Thank you, Dr. Narasimhan. So, Dr. Vishal, one question which I would ask you is, I'm also a medical doctor, and during our, training, I think, psychiatry was an elective subject. We had 15 days of internship. It was kind of the last on the, list of priorities because we focused on treatment rather than prevention and stuff like that. From an academic point of view, from a pedagogy point of view, how do you think, and how do you think that these two departments of especially areas which deal with chronic illnesses and mental health can work more synergistically? Because I'm a big advocate that you are what you think and what you feel. So, and you are an institution builder. So how do you think we can really make that grassroots level change in at least starting from medical colleges onwards?
So as we are closing, I'll close it on a lighter note. I think, I must tell you, when I was doing my medicine, skin was not a favorable. Everybody was running towards clinical subjects, which are surgery, general medicine, radiology. Skin department was ज़्यादा लोग पूछते नहीं थे. So, my colleague who used to be always moving around in the leprosy ward, syphilis ward, this ward, he used to keep envying me as a surgeon. He used to say, अरे यार boss, तुम लोग यहाँ पे OT में हो. थोड़े टाइम पहले we both interacted. After 25 years we are interacting, and he's telling me, I said कहाँ पे हो? He said यार बॉम्बे आया था one of the Bollywood actors के लिए botox करने के लिए. And I was sitting, I'm telling him, I said थोड़ा गले के नीचे भी देखो, कुछ thyroid है तो बता देना. I said times have changed because and I was in US some time back, and my friend who's now the psychiatrist there said, I just bought a plot next to Elon Musk's factory. And my physician friend was sitting silently there, not mentioning much. He said, I'm still in my rented apartment. So I'm just trying to tell you all that things have changed a lot. So, but I think the more important, relevant part for me today, the way I look at it from an institution point, telling medical student others, is every branch is beautiful. The question is, at this point in time, Gen Z, Gen Alpha, you'll have to open up and break the rules. It is going to be disruptive. It has to be disrupted. It cannot go the old way. Technology has to come in. Disruptions have to come in. So how are we going to do it? It's our generation that has to let it go and allow them to do it. And that's what I'm encouraging people. So I'm trying to do first year medical students. I'm trying to teach them robotics to understand so that they can get hold of technology. And same way I'm trying to tell them that in the next 10 years, we'll have to look at future-proofing ourselves. And I will use the word mass customization, which means that like Starbucks does mass customization, correct? It just sells coffee, but there's a customization in this whole thing. Our branches are going to be fused. So a pathologist will be sitting inside the radiologist because the radiomics is going to take over. The radiologist will be doing the pathology business. Similarly, a clinician will not be able to do any work without a psychologist or a psychiatrist working with them. This is going to be so interconnected. So please come out of your silo. Please understand that it's not about one single standalone branch that is going to take you to the pinnacle of your success. It's going to be the collected effort of team efforts that are going to do it. And that's what I'm seeing today. I may be a good surgeon, so I may be doing the most complicated robotic surgery, but if I don't have a comprehensive psychology team, a rehab team, I'm just as useless as any other surgeon, because anybody can remove that tumor. The question is, how do you integrate it to give that patient that holistic experience of healing rather than curing? So I think that shift is happening, Preeti, everywhere. And I think NMCs, global universities, I'm now traveling to so many global universities. All of them have opened up to the thought to say that it is going to be fusion medicine. It's not going to be one single thing. It's going to be clinical scientists. It's not just about sitting in the clinic. I'll have to go into the lab, spend my time into lab. And that's what's changing, and I'm changing. So I'll just end with one thing with our physicians. What happens is COVID took a toll on us. And my chairman, after first wave, second wave, third wave का कुछ rumor चल रहा था. So my chairman told me, we shall go and give a motivational speech to doctors. I said, sir, क्या motivational speech दूँ? He said, सारे थके मारे बैठे हुए हैं. I said, क्या motivation दोगे? He said, नहीं, we have to keep them upbeat and ready. I said, we have nothing left now to get motivated. Ganti is over, everything is over, nothing's working. I said, just the brain stopped functioning. So he said, no, we have to be ready, you have to go. So I went, I did some background reading, and I thought I'll go ready for a good speech. So I went to a hall like this full of doctors, and I looked at them and I said, look, there's some new data that has come out that stress is a healer. And they all looked at me. Yeah, I had nothing else to say because everything else is over. So they all stared at me and said, ये कहाँ से लेके आए, So I said, no, मैं genuinely study कर रहा था कि there is good data to show that stress can be a healer. And then there was stoic silence in the room, and they all looked at me saying, this is too much, this is another level. I said, no, I said, serious. So let's start talking the third wave, I said. So I think for us, for the second victim, as what he said, it's a never-ending game. See, if you are not in a good state today, you cannot deliver your best to the next patient. So I think the point he's making, whether it's danger, whether it's a TV9 waiting outside your office or hospital, or whether it is some violence happening, we are people who are living with this and somehow coping with it. We also need to go through our own process of churning, because we need to, what we call catharsis. We need to have our own catharsis, and it's the time for us to look at integrated medicine, where we all have to be strong enough if you have to play the next innings in a strong way. Thanks.
Thanks, Dr. Vishal. So I can take a couple of questions from the audience now. Yeah.
The difficult ones you can direct to Narasimhan. You have a philosophy. So I said.
See, I'm a colorectal surgeon. I can take anything. Shit hits me, but I take it.
Okay, can I ask? Do you think there is an over data that, there's like this death by data, like a lot of us do too many tests, but also, like you said, the hospitals have become so commercialized, they also constantly recommend doing tests. Is there a flip side to how many tests our generation is kind of doing? We do these comprehensive yearly tests and probability of getting cancer. There are so many of these things that have come up, along with AI and the wearables that we wear that gives you so much data. What is your take on how much as lay people are we consuming medical information?
See, I'll give you a perspective, both from a European view and Indo-American view. I spent 2 decades in the UK, spent a year in the US, some time in Germany, Portugal, etc. The whole business of annual health checks doesn't happen in Britain. Not that NHS is trained, of course it is trained. But I think the question you asked is, I think we truly are overburdened with the tests we do. The most important thing for anybody to say is, have I got a problem? If there's a symptom, you have to go to your doctor. But I think just going to your doctor or just having a screen every year doesn't prevent from you having problems or diseases. Let me give you an example. I'm a colorectal surgeon. I take back and a youngster comes, 20-year-old. Sir, I have got bleeding in the back passage. I'm very scared. So majority of them are boys for some reason, because they drive, they sit, whatever. Eat, not the right things, not fiber, not drink enough water. So they come shit scared. Doctor, I'm bleeding. And majority of them are engineers and IT engineers. So I say to them, boss, women bleed every month. They don't get scared. Why are you bloody scared? And more often than not, you ask them 3 questions. Is it painful? They say yes. Does it hurt? Yes, it hurts. Are your stools hard? Yes, they are hard. Is it mixed with the stools? They say no. More often than not, it's just a tear in the back passage. The same patient lands up with a general physician or a GP or a doctor. They get CBC, they get RFT, they get LFT, they get a colonoscopy. And in colonoscopy, what happens is, it's all commercialized so badly that they say grade 2 hemorrhoids or grade 1 hemorrhoid. this guy is shit scared, Googles everything, and the next thing he does is picks up a phone call to Practo or Smiles or somebody, and that's a bloody call center. They'll say, no problem, sir, we'll send you a cab tomorrow morning, land up, insurance is processed. And here is a doctor looking at somebody's bum, doing a procedure, hasn't even seen his face. He gets an operation. 80,000, and this is true reality. Practo, a unicorn. Okay, why is it gone down? Think about it. Okay, likewise, there are so many things that are happening around us which is not necessary. And these guys have an operation, a laser procedure, for something that they don't need an operation. And about 5% of them, about 1 in 20, land up with complications to me or somebody who does advanced work with fistulas and this and that and whatever. So what I'm trying to say is, I think we have stretched the system with too many tests. See, the best test one can have is a clinician time and a clinical examination, which we don't do. I think that is what we have to really think about. And I think we really have to spend time with the doctors who can understand what it is, tell you what it is. And no test can prevent anything. If it has to happen, it will happen. But what you need to be aware of is, what are the symptoms? What do I need to be aware of? Have I got the risk factors? And I think be mindful. Google less, at least Google the right way. See a friendly doctor. And I worry, I work at Apollo, don't get me wrong. And I worry taking my parents to Apollo. No, that's truth. The reason is because it's very difficult for somebody to sit down, talk to them, put that confidence in them, and do it with minimal cost. I think India is a country of villages, and think about those people out there. And I still practice the British way. I still look at my NICE guidelines. I still do my British practice because they treat the population. The Indo-American way is they don't even put a finger into the bottom. The patient is already on chemotherapy and radiotherapy. I have my own friends who have gone through treatments elsewhere. द्वार में खून निकली, MRI किए, PET किए, छोटा सा ट्यूमर है, हिलता है, you can just nip it off. But they had radiotherapy, they had chemotherapy, the whole thing is burnt out. Unfortunately, somebody who is 40, can't have sex, can't have proper toileting, can't sleep because he has to go to toilet so many times. So he's got a functional problem, chronic pelvic problem, when he could have been dealt with and sorted with a small procedure. So what I'm trying to tell you is, decisions are more difficult than incisions. And unfortunately, we are in a country which is driven by capitalistic healthcare, and I think that's a problem. So you need to be mindful of that.
Thanks, Dr. Narasimha. We can take a couple more questions. Yeah, the lady in white. Yeah.
Thank you so much. I think it's been such a wonderful, insightful, discussion and conversation. A quick question and a follow-up question to Dr. Narasimhan. If a parent is diagnosed with colorectal cancer and, of course, has passed on, what are the chances the child or risk factor for the child or the children? That's number one. And number two, if there is a risk factor, what are the things one needs to keep in mind, and how often should they test themselves, and what kind of tests are recommended?
Thank you. I think it's a very vital question. So I take you back to my initial statement I made. Majority of the cancers are driven by age, stage of evolution, and these are called as sporadic cancers. Sporadic is age-related, evolutionary cancers. The cells, when they keep changing in oneself, whether it's the skin or the hair or the genitals or the breast or whatever, the cells, when they keep changing, the more number of cycles they go through, there's a possibility that the genetic material in them goes through change. And this change is driven on the DNA and the RNA, the ATGC sequence. And a bad cell is born. And that bad cell is normally killed by the system, by the system's vigilance system. And we call this process as apoptosis, programmed cell death. When the body loses the ability to identify and kill this, these cells grow very fast, very rapidly to become a lump. That is all cancer is. Cancer is nothing more than this. So majority of the cancers we see are sporadic cancers, which is about 60 to 65%, comes with age and the risk factors we have exposed ourselves to. There is a 25% of the cancers which are familial cancers. What I mean by familial cancers is the cell had changed, but because there was a dominant aspect of the cell, the parent did not get a cancer or got a cancer. So one of the genes is passed on to the kid. So they are at risk, but high risk. And these are familial cancers. Dad had it, mom had it, grandfather had familial cancers. This is about 25%. So 65% is sporadic, about 60 to 65. 25% is about familial cancers. There is another 5 to 10% something called as genetic cancers. So when you are born, the cell dictates that you will have a cancer. It is written that you will get a cancer. For example, Angelina Jolie. So this is the BRCA cancers. Colorectal cancers, the FAP. So these are genetically driven cancers, and it's written that you will get a cancer, and we know these genetic cancers. So about 65 are sporadic, about 25-30 are familial, about 5 to 10 are genetic cancers. So the moment there is a risk in the family, suppose there's a parent who gets cancer at 50, colorectal cancer, one, you have to be mindful of the symptoms that one may expose themselves to or one may experience. And I would start the screening at least 5 to 10 years before the onset of the cancer in the parent. Suppose if the parent had a cancer at 50, I would say, chalo, let us get a colonoscopy at 40. Okay, so I think bringing back the period of screening by about 5 to 10 years is a good thing when it's a familial cancer. Being mindful of the symptoms is very, very important. And of course, there are non-invasive methods too these days. You can have fecal immunotests, you can have, though they're not 100%, but the gold standard test is actually a colonoscopy. So I think you need to have a clinician who can understand, who can make you understand what is going on and give you that ownership to take care of your health. I think that's what needs to be done. I hope that answers your question, madam. Thank you.
I think I wanted to ask a question actually. Yeah. That was an insightful talk by the entire panel actually. So we were talking about the gut health, and the gut health says that what you eat, that's what we are made up of. So in this era of the hybrid vegetables as well as everything is being commercialized, so how do we general public should take care of their gut health and keeping it to the optimal level? That is the one thing which I would like to ask.
So my question is, how can we integrate complementary systems of medicine along with modern medicine to give holistic care to patients at any level? So chronic pain also includes conditions like fibromyalgia and other things where patients are suffering on a daily basis and they're not getting the kind of relief they want to get, and they cannot be on lifelong medications as well. So how can we contribute?
Yeah, third question. One more, last question. Yeah. Person with the back.
So we'll answer all of that together.
Yeah.
Hello panelists. So I want to ask a question which concerns how important is the order of care, especially in complex diagnosis, like for example cancer or stroke care, post-surgical care, etc., etc. But for lower socioeconomic people, and you see sometimes consulting someone before and then going to the next doctor and then next doctor, sometimes order of failure, in cases where the prognosis is multi-organ failure or something, but sometimes we have to treat something before the next thing comes up. So how important is prioritizing, whether solving this problem first would help better, or solving this problem first before would help?
We get the point.
Got it. Yeah, thank you. Thanks for your question.
I think I'll make quick comments and then I'll give it over to Narasimhan. To start with gut health, see, we are in a real troubled inflection point, especially in India, with regarding to food safety. I was just some time back talking to the food commissioner on this. Telangana was doing some raids. Karnataka should start some raids soon. But this cotton candy business in Gobi Manchurian won't do. It's just eyewash, the whole thing has to change in a much structured manner. And I was telling them, pesticides, preservatives, adulterants are become the rule of the day. GMOs. So today it's really a concerning thing. And I think the first top priority above tobacco and alcohol is food. That's where we'll have to, because this food is the one that's leading to random IBS, lactose intolerance. The food is because you don't know what they're adding into it. I don't want to spoil your dinner today, but I'm just intending to say that there's a lot of bad data out there to say that the food quality and control is not being matched to the level we have to do it. So we are living in an instant, unlimited and a more era. We want instant coffee, instant burger, instant marriage, instant love, instant whatever. And we want unlimited food, and we want buy one, get three free kind of a... So that itself, I think, is leading to some gut problems. And I had a farmer who came to me and said, sir, ये मैंने आपके लिए बनाया है, fruits मैंने आपके लिए लेके आया हूँ, जो मेरे फार्म से है, जो मैं बाहर बेचता हूँ वो सेपरेट है, तो आप लोग जो खा रहे हो वो सेपरेट है, मैं जो खा रहा हूँ अलग है बस. FYI, मतलब ऐसा, if this is the kind of scenario where actually they are doing separately for themselves because they have to pump the entire thing into, that's the amount of thing. What the food commissioner told me very interestingly was, with the agriculture department, that the farmer doesn't know exactly how much of pesticide to put. So he thinks more is better. Calcium carbide is being used because the market you can't wait for the fruit, that's a mango or a banana to be wait ripe. So they put it in a gas chamber filled with calcium carbide so that it rapidly ripens. To a person adding instead of beef bones, they have added dog bones in refining sugar. It's going crazy. So somewhere we have to clip at the level of government, and we've been impressing upon the government to say that unless the government intervenes here, it's going to be bad. So for the gut, definitely food and food activism from the civil society to ask for safer food is going to be the answer. To the second question, integrated medicine, I would fully bet on it and say that the future is integrated medicine. You cannot segregate one from the other. It's got regulatory issues, it's got political issues, it's got scientific issues, but across all of the three, there is, I think I was talking to somebody from Transdisciplinary University. I think this is the place where already things have started to collaborate. We ourselves are very actively collaborating. I work with healers, I work with alternative medicine, complementary medicine. It's time to actually address this. In US, the data shows, New England Journal of Medicine, that 30% of them actually use these therapies without telling the primary clinician because they think that they don't believe in it. I have tried to change the ecosystem at my center to say have an openness to share. So I talk to the Ayurveda expert or another expert to tell them what is it that you are giving. Please let us know so that we are able to help you complement the science. So it's already started. It's going to be the future. To the last question, what the girl asked there, I want to just tell you one thing. See, remember, like I think Narasimhan put it beautifully, succinctly, that simplified. AI, all this. I said before AI, you should understand natural stupidity. See, natural stupidity is not, AI is not the solution for natural stupidity. And what we are currently in is natural stupidity at the peak. And we are using AI solutions for that. It's not going to solve it. Ultimately, I feel the answer is simple, good clinical medicine and understanding how health can be moved from illness to wellness. That's the shift we have to do. And in that, there is a clear thing. If you go to the oldest racks of the books on clinical medicine, they've given a simple algorithm on how to reach prioritization. So I'm saying it's a big topic, but overall what you should know is we are in the era of evidence-based medicine, and boss is from UK. So I'll tell you a nice article from British Medical Journal which I liked. It was called The Role of Parachute in Saving Lives in People Who Are Jumping Off from an Aircraft. Very shocking. I said, ऐसा कैसे study publish हो गया? So I read through it, and the conclusion was that no, parachute is not safe at all. I said, then what else is safe? But then I opened the page and I saw that there was a static aeroplane and there was a girl standing on it and jumping from there from 4 steps like this. So the study was saying randomized control trial. So what I want to tell you is, as a surgeon, I can with my life kill one person. A statistician can kill this whole hall. So wrong data. So the whole problem with today's marketing is that 5% commission and 95% omission, and then after that the product is sold, is a big dangerous trend for us to kind of look at. So clinical medicine has very clear guideline. We just need more of Narasimhan, good doctors who can be vocal about all this and talk about it.
So, I mean, just a comment on what he was asking about food and how good it is. Okay, you know whom I blame? I blame the Americans. The whole business of fertilizers came in post-World War just because, you know, they had to pump up the production. And unfortunately, we have carried on. Today, we are in a state where every food product we consume is contaminated. The soil is contaminated. So how guaranteed you are to say that it's organic? Organic Mandya is a big firm, big, institution which produces organic food. The water goes from Rushabhavati, so you know how good it is. Any organic, you look at it, it's very difficult to rely. The best thing is, see if you can have a piece of land or even a kitchen terrace garden. Grow what you can, and majority of the times, you can rely on what you grow, sort of thing. And I think, sufficiency is the answer. And I think the more refined and sophisticated you go, the problematic it is. And don't be too clean. I mean, I'm making this bold statement because I do a lot of fecal transplants, and, the more hygienic you are, I think you have killed your system, the ability to produce immunity. I think that is one of the major problems with a lot of us, because a lot of us are OCDs, a lot of us are hygiene possessive. And when really COVID hit us badly, the first place to be safe was the Dharvi slum. Okay, so I think let the mother nature take its call. For example, when people have diarrhea, let them just go through this because they'll start developing immunity to it. That's the whole purpose. So I think we should just go back a bit more natural. And, the whole business of bottled waters, microplastics is one other big problem, as Vishal was mentioning. So I think let us just go what we were 25, 30 years ago, a bit more natural, a bit more less sophisticated, and let us be self-sufficient is the answer for your question. I hope, that clarifies. And I think, what was the second question you asked? I wanted to, Vishal has done a great job. And I think if you take back to HCG data, I remember a paper that came in 2012 or 11, I can't remember, looking at stage-matched breast cancers. Americans did what they did. HCG, they picked up a group of patients, stage-matched, put them through Kundalini Yoga, meditation, a structured integrative approach, integrating Ayurveda and, other complementary systems. And they looked at science, they looked at their survival benefit, they looked at quality of life benefits, and they also looked at markers, biochemical markers of inflammation. They looked at interleukin-1, interleukin-6, tumor necrosis factor alpha, interleukin-8, and surprise, the Indian group were more happier. There is a marginal benefit in the length of survival, and all their pro-inflammatory cytokines were much lesser. So there is surely a benefit from integrative medicine, and Apollo has now tied up with Ayurveda. In fact, Ayurveda is a part of Apollo now. So I think allopathy is good to cut it out, but preventive and rehabilitation and rehabilitation lies in the complementary therapies. And if you look at some of the sadhus who talk about life and illness, you look at Isha Foundation Sadhguru, you just think, where did he bloody get this knowledge from? He has got so many talks on cancers, and if you actually listen to it, it makes so much of a sense. So I think spirituality plays a role, Ayurveda plays a role, naturopathy plays a role, and the mother's love, care, affection, and the familial bonding, the most strongest, I think, something we can't ignore. Thank you.
Thank you. I think that's a wonderful note. Unfortunately, we'll have to close. If we are getting an hour with doctors, I think we just get greedy. We want more and more of that. So thank you very much. Thank you very much, Preeti, for organizing this, because you really facilitated these discussions. You brought the doctors on board. Thank you, all of you here.